Hi, I'm Shannon McPhee. I'm an associate professor of emergency medicine at Dalhousie University. Over the next 15 or 20 minutes, we'll talk about pediatric sepsis. Sepsis kills. By the end of this presentation, I'm going to arm you with recognizing the risk factors for pediatric sepsis, to understand the importance of the critical heart rate in pediatric sepsis, and to be familiar and to be able to execute the treatment algorithm to help save a life. Starting off with 3 questions. Ceftriaxone is the drug of choice for pediatric sepsis in an otherwise healthy child with no allergies. So I'll have you mark down your answer to that. The second question is, blood pressure must be low, so below the 5th percentile for the patient age, to make the diagnosis of sepsis in children. And that's true or false. The third is a clinical vignette. An 8-month-old baby presents with a rectal temperature of 39, heart rate of 168, rest rate of 32, blood pressure of 72/40, and is alert, warm, has a cap refill of 2 seconds. You have 3 options. The first option is to initiate the severe sepsis protocol and start with normal saline 20 mils per kilo and administer ceftriaxone. Your second option is to monitor the patient as per the CTAS score, repeat the vital signs as indicated or as the patient condition warrants. And your third option is to discharge the patient home, as the elevated heart rate is probably caused by the increased temperature. One of the most important parts is understanding who is at higher risk for sepsis. And so I'm going to give you a couple of minutes to think about 5 underlying conditions that would put a child at higher risk for sepsis. And these are the learning outcomes that we talked about at the beginning of the presentation. One of the things that will be really helpful is to review the TREK algorithm for pediatric sepsis. And this can be found at trek, TREKK.ca. And this is a knowledge mobilization network that distills the most up-to-date evidence for pediatric emergency conditions. And there are a number of great resources on there, including pre-printed orders. There are posters for triage, as well as some of the pediatric vital signs cards that we have. It's all for free. It can be used at your institution. And so when we go forward in this talk, this evidence has really been brought to us by TREK. And so the first case is a 2-year-old child, and this patient comes into your emerge with a temperature of 39.4. The heart rate is 168, rest rate is 44, blood pressure is 70/35, and the SATs are 94%. Sometimes kids can be difficult to examine, and this particular patient comes to you in the middle of the night and you can't really decide whether they're sleeping or whether they are truly difficult to arouse, but the patient is definitely mottled. The extremities are cold and the cap refill is 5 seconds. And you can see part of the new rash on this patient's chest here and the back of her neck. And if you were able to look up close, I can tell you that it is petechiae. It is a non-blanching rash, 2-year-old child. And so every patient that comes in, you need to go through the same set of questions every time. So the first question is there a critical heart rate? The second is, are there signs of infection or a high-risk medical condition? And so for this particular child, there are definitely signs of infection. So the patient has a fever higher than 38 degrees. We've got a new rash that wasn't there before. And the third question is, are there signs of severe sepsis or shock? And that really comes down to, is there poor perfusion or are there mental status changes? And so this particular patient has a cap refill which well exceeds 2 seconds. The SATs are below 94 and the extremities are cold and mottled. I can tell you that for many children, they can have mental status changes, and that can be really difficult for somebody that's working in an emerge department because we're not familiar with that child. And it may be not clear to you what the developmental status of the child is. And so if you think that they're acting confused, take that moment to ask the parents, is this what the normal behavior would be like for this particular situation? Just so that we have an understanding of what's going on. So this patient here definitely meets the criteria. I am concerned that the patient is septic. And one of the most useful tools that any emerge provider can have is a sheet of vital signs cards. It is almost impossible to remember all of the vital signs by age, and you need to have that at your hands. And so this should be posted in your triage area, and if possible, these are available in lanyard sizes so that you can have them with you all the time. Blood pressure also can be difficult to remember, and so for babies who are under 1 month, a 5th percentile blood pressure would be less than 60 systolic. For infants who are between 1 and 12 months, the systolic blood pressure below 70 would be concerning. And then we can use an equation for children between 1 and 10 years, and so 70 plus 2 times the age should be your 5th percentile blood pressure for those kids, and anything below that should be very concerning to you. And once kids get to be 10 years of age, we use the lower limit of 90 systolic. So what happens with sepsis in kids? So this is a graph of heart rate and blood pressure over time. And your heart rate will continue to go up. Kids' hearts are a very strong muscle. And if you wait until the blood pressure falls, it will be too late. So kids' blood pressures hang on for a long time. And by the time that they start to deteriorate, that kid is really sick and you've probably waited too long. And so we really want to catch these guys early. We want to catch them when they just have a critical heart rate. Waiting for the blood pressure would be unacceptable. This is a triage poster that really goes through the kind of things that I've been talking about. So the first question being, is there a critical heart rate? Are there signs of infection? And we'll talk a little bit about some of the underlying conditions. So about 40% of children who have sepsis have an underlying comorbidity. And I think we do a great job of recognizing children who have an immune deficiency, so either because they're on oncologic treatment or because they have an underlying immune disorder. I think we also do a fantastic job of recognizing that infants under 3 months are at increased risk of sepsis because their immune systems have not fully developed. But I want you to add to the list that children with neuromuscular conditions and developmental delay may not respond in a normal way to infection, and they are at high risk. Children with severe cardiac abnormalities, severe respiratory conditions such as cystic fibrosis may not respond normally. And you really need to pay close attention to how those children are coping with infection. And I would say the one that can slip through our cracks fairly easily is if they've had recent surgery. And so even previously healthy kids who have undergone a routine surgery, such as an appendectomy perhaps, they're at high risk for sepsis and account for about 27% of patients. And the reason I'm taking a long time to underscore that is that when they come in with a high heart rate, your reflex might be to say, well, they've just had an operation and there may be an element of pain. So that may be one reason that the heart rate is up, but you have to put sepsis at the front of your mind so that we don't miss this particular group. Once you've ascertained that there's a critical heart rate, they've got a setup for sepsis and have signs of infection, you really need to look for either perfusion changes or mental status. And it's only that group that we move forward with and we go forward to the sepsis algorithm. There are going to be lots of patients who have a high heart rate. They may have signs of infection, but they're still perfused, they're still alert and awake. That particular category fits into that blue box there. You're going to go back and reassess them multiple times. You're going to do a very thorough physical exam and have a thoughtful approach to care. You may keep them around for a little while to make sure that the heart rate does come down. And so that particular group needs reassessment, but the kids who are showing poor perfusion are going to jump right into the algorithm. We'll keep it simple. From a sepsis perspective, we expect 3 things. We expect 1, fluid recess. Second thing we need is antibiotics. And the third thing are pressors. So moving along in terms of fluid resuscitation, we know that when children are given early fluid and fast, we have a lower mortality rate. And so this particular study here shows that the mortality rate of children who had 320 cc per kilo boluses was 8%, and those who did not receive fluid in that timely fashion, the mortality rate, which was much higher at 38%. So that's a cornerstone of therapy from the beginning. And the big question is, how do you get it in there? And so I think if you're working in a facility that's accustomed to dealing with adults, you often would use a level 1 infuser or a rapid infuser. That's a very acceptable choice for children who are heavier than 20 kilos. But what you're going to find is that for babies and toddlers who weigh less than 20 kilos, the rapid infuser is not going to work for the volume that you need to get in there. And so for that particular group, you need to have a plan. And we use what's called the push and pull method. And so if you just hook the fluid up on one of the smart pumps, it's not going to get in there fast enough. We want this bolus in there, over 5 or 10 minutes. And so you're going to draw off a normal saline bag and push the fluid in there using a clean syringe every time that you do it. Once you've hit your second 20 cc per kilo bolus and your patient is still poorly perfused, it's at that time that you should ask to have your epinephrine infusion start to be prepared. So we really recommend 320 per kilo boluses, but it does take some time to get an epinephrine infusion running, and that needs to be sort of started right away. And so your plan after that, for the most part, is going to be epinephrine. Norepinephrine is recommended for warm shock, which we don't see very often in children. We're really, for the most part, looking at a cold shock, and so epinephrine would be the most common thing that you'd use in this particular scenario. In terms of investigations, blood cultures ideally should be obtained before starting antibiotics, but we know in a child who is peripherally shut down that can be fairly difficult. And so if you have a kid who's decompensating in front of you, if it is difficult, you've tried the blood culture and it doesn't work, just give the antibiotics. And I would say the same for lumbar puncture. So if you have a perfectly stable patient and you've got experience doing lumbar puncture, absolutely go ahead. But if you have a patient who's crashing in front of you, whose level of consciousness is not good, whose SATs are low, you should move forward with your antibiotics before those tests. In kids, it's simple. It's ceftriaxone, 100 milligrams per kilo. You can give this IV, and if you're unable to get an intravenous, you can easily give this intramuscularly. You can also give it via the intraosseous. Vancomycin is reserved only for those children where you are concerned about meningitis, and so if you think that there's nuchal rigidity or any other signs of meningitis or a very altered level of consciousness, that would be your option for those particular patients. The goal is to have the antibiotics in within 1 hour of presenting at your institution. So we'll go back to the case that we presented. That particular patient received normal saline 20 mils per kilo 3 times. There was no improvement. And so the patient went on to have an epinephrine infusion started. Her level of consciousness continued to deteriorate, and so she was intubated and admitted to an intensive care unit. She actually improved over the course of about 7 days, and her blood cultures grew group A strep. So circling back to some of the questions we had in the beginning, this is absolutely true. So ceftriaxone is the drug of choice for pediatric sepsis. You can give it intravenous, intramuscularly, and also intraosseously. Second question is, blood pressure must be low, below the 5th percentile to make the diagnosis of sepsis in children. And the answer to this one is absolutely false. We don't want to wait until the blood pressure is low. We want to catch them early, and you can absolutely have sepsis with a normal blood pressure, but instead we'd expect to see critical heart rate. The third question, this is the one with the 8-month-old baby who had a fever, tachycardia, with a normal blood pressure and looked well with good perfusion. And the answer for this one is B. This patient does need to be re-examined because of the high heart rate. But given that the child looks well, it would be appropriate to give the child an antipyretic and go back and reassess that patient multiple times until you are happy with how they look. And in terms of the 5 conditions that may put a child at higher risk for sepsis, These can include immunocompromise, either because of their medications or their underlying condition, cardiac, respiratory diseases, neurodevelopmental delay, as well as recent surgery. So to leave you with a few take-home points, early recognition is key. Take the heart rate seriously. Look very carefully for signs of infection, with particular emphasis on those people who have high-risk conditions, including recent surgery. Every time you need to assess for poor perfusion and altered mental status, and you've got 3 priorities in these cases: fluids, 20 cc's per kilo of normal saline times 3. Antibiotics, so ceftriaxone, must be given within 1 hour of presenting at your facility, and you're going to move on to vasopressors if the fluids aren't doing it. Thank you.